Hello, good morning. Please sanitize your hands. This is Ramavath Abhilash. I am a second year medical student. Today I am going to inspect your chest, thorax. Mm, what's your name?
Sure.
Okay. What's your age?
20.
Okay. What's your occupation?
Student.
Are you single or married?
Single.
Now I am going to take your past history. Have you done any surgeries before?
No.
Okay. Have you hospitalized before?
No.
Have you undergone your vaccinated program?
No.
Okay. Have you undergone any test before?
No.
Okay. Do you have any childhood illness?
No.
Okay. Do you have any complications in the adult history?
No.
Okay. Are you taking any medications right now? Are you having allergies?
No.
Okay. Now I'm going to ask about your family history.
Okay.
Please tell. Okay. What's your parents' occupation?
My father is a police and my mother is a doctor.
Okay. Do they have any sickness like BP or diabetes?
No.
Okay. Mm, in your family there is any genetic disorder like that or any cancer?
No.
Okay. Now I'm going to ask about your personal history. Okay. What you're studying?
BA.
Okay. Do you prefer home food or outside?
Home.
Okay. Do you exercise regularly?
Yes.
Do you have any stress?
No.
Okay. So now I collected your information. Now I'm going to proceed for the further steps. Is that okay with you?
Okay.
Okay. If you have any doubts or clarifications, please tell me.
Okay.
Okay. Okay, thank you.
Thank you.
Can you please remove your shirt so that to better visualize of your chest? Is that okay?
Okay.
Is it comfort for you?
Okay.
Okay,
First, we have to inspect the hands. Both hands should be symmetrical color and symmetrically warm. Look at the nails carefully for clubbing. Present in pulmonary fibrosis, cystic fibrosis, and bronchiectasis. In rarer cases, it could be an ominous sign of lung cancer. View the fingers from a dorsal and lateral view and note the width of terminal portion and compare with the proximal part and look at the angle between the nail and skin. And clubbing may result from chronic low blood oxygen levels. Ask the patient to show the tongue for the central cyanosis or any oral candidiasis. Now inspect the neck, and during inspiration there is contraction of sternocleidomastoid muscle and scalene muscles, and during expiration there is contraction of intercostal muscles and abdominal oblique muscles. And also observe the chest for symmetrical breathing and observe for any chest wall deformities like barrel chest or pectus carneatum or pectus excavatum, kyphosis or scoliosis. And also see the cricosternal distance.
There is no signs of respiratory distress and my patient's respiratory rate is normal. Now I am going to check for the shape of the chest.
Standing in a midline position behind the patient, note the shape of chest and how the chest moves, and any deformities or asymmetry in the chest expansion, and abnormal muscle contraction or impaired muscle movement. Now in palpitation, place the thumbs at the level of the 10th ribs and watch the distance between your thumbs as they move apart during inspiration and feel for the range and symmetry of the rib cage as it expands and contracts. This movement is sometimes called lung excursion. Now palpate both lungs for symmetric tactile fremitus. To detect fremitus, use either the ball bony part of the palm at the base of the fingers or the ulnar surface of the hand. Ask the patient to repeat the words 99 or 111. Confirm any disparities by listening for underlying breath sounds, voice sounds, and whispered voice sounds. All these attributes should increase or decrease together. Now, the third most important technique is percussion. The percussion helps us to establish whether the underlying tissues are air filled, fluid filled, or consolidated. Now hyperextend the middle finger of the left hand, the known as pleximeter finger. Press its distal interphalangeal joint firmly on the lung surface to be percussed. Avoid surface contact by any other part of the hand because it dampens out vibrations. Note that the thumb and second, fourth and fifth fingers does not touching the chest wall. With the flexor finger, strike on the distal interphalangeal joint of the left finger. Percuss twice in each location and listen for differences in percussion notes at the two locations. Percuss one side of the chest and then the other at each level in a ladder like pattern. Now identify the descent of diaphragm or diaphragmatic excursion. First determine the level of diaphragmatic dullness during quiet respiration, holding the pleximeter finger above and parallel to the expected level of dullness. Percuss downward in progressive steps until dullness clearly replaces resonance. Confirm this level of change by percussing downward from adjacent areas both medially and laterally. Now estimate the extent of diaphragmatic excursion by determining the distance between the level of dullness on full expiration and the level of dullness on full inspiration, normally about 3 to 5.5 centimeters. And now auscultation is the most important examination technique for accessing airflow through the tracheobronchial tree. It involves listening to the sounds generated by breathing and listening of any adventitious added sounds. There are four kinds of breath sounds. There are vesicular, bronchovesicular, bronchial, and tracheal. In vesicular, inspiratory sounds last longer than expiratory sounds and it hurt almost both lungs. And in bronchovesicular, inspiratory and expiratory sounds are almost equal and it heard at first and second interspaces anteriorly and between the scapula. And in bronchial, expiratory sounds last longer than inspiratory ones and it heard over the manubrium. And the last one is tracheal. Inspiratory and expiratory sounds are almost equal and it heard overall the trachea in the neck. And now listen for added beat sounds. There are two types, discontinuous and continuous. In discontinuous there are fine crackles and coarse crackles, and in continuous there are wheezes and rhonchi. And now starts the examination of anterior chest. First we have to inspect the shape of the patient's chest and the movement of the chest wall, and we have to note any deformities or asymmetry of the thorax and abnormal retraction of the lower intercostal spaces during inspiration or any supraclavicular retraction, and also see for local lag or impairment in the respiratory movement. And now start palpation. Palpate the anterior chest wall for identification of tenderness or assessment of bruising, sinus tracts or other skin changes. In assessment of chest expansion, place thumbs along each costal margin and raise loose skin folds between thumbs. Ask the patient to inhale deeply. Observe how far thumb diverges as the thorax expands and feel for the extent and symmetry of respiratory movement. Now access for tactile fremitus. Compare both sides of the chest using the ball or ulnar surface of the hand. Fremitus is usually decreased or absent over the precordium. Fremitus refers to the palpable vibrations that are transmitted through the bronchopulmonary tree to the chest wall as the patient is speaking and is normally symmetric. And note the differ in the basic qualities of sound intensity, pitch and duration on both sides. And now the third most important step is percussion. Percuss the anterior and lateral chest, again comparing both sides. The heart normally produces an area of dullness to the left of the sternum from the third to the fifth interspaces. And now percuss for liver dullness and gastric tympani. With pleximeter finger above and parallel to the expected upper border of liver dullness, percuss in progressive steps downward in the right midclavicular line. Now we have to identify the upper border of liver dullness so that we can estimate the size of the liver. The hyperresonance of COPD may obscure dullness over the heart. The hyperinflated lung of COPD often displaces the upper border of the liver downward and lowers the level of diaphragmatic dullness posteriorly. The dullness of right middle lobe pneumonia typically occurs behind the right breast. And now lastly, start auscultating. Listen to the chest anteriorly and laterally as the patient breathes with mouth open and somewhat more deeply than normal. Compare symmetric areas of the lungs using the pattern suggested for percussion and extending it to adjacent areas. Listen to the breath sounds, noting their intensity and identifying any variations from normal vesicular breathing. Breath sounds are usually louder in the upper anterior lung fields. Bronchovesicular breath sounds may be heard over the large airways, especially on the right. And also identify any adventitious sounds, time them in the respiratory cycle, and locate them on the chest wall. Abnormal retraction occurs in severe asthma, and lag occurs in underlying diseases of lung or pleura. And now this completes the anterior examination of chest.